This recording will go over pharmacokinetics, pharmacodynamics, and also routes of administration. So pharmacokinetics refers to the movement of drugs throughout the body, whereas pharmacodynamics, which we'll talk about later, refers to the body's biological response to the drugs. So pharmacokinetics, if you see that term kinetic, you should be thinking movement. So movement of pharma or drugs throughout the body. There's 4 phases: absorption, distribution, metabolism, and excretion. Absorption is the transmission of medications from the location of administration to the bloodstream. So basically, absorption is when the medication gets in the bloodstream and is able to start traveling throughout the body. Different types or routes of administration affect the absorption of a medication. The rate of medication absorption determines how soon the medication will take effect. The amount of medication the body absorbs determines the intensity of its effects. The routes of administration affect the rates and amount of absorption. So first we'll talk about oral administration of medication. With oral administration, the medication must pass through the layer of epithelial cells that line the GI tract. So we'll think of a tablet, an acetaminophen tablet, so Tylenol, right? So I have a headache, I'm going to take my acetaminophen. I have a tablet or 2 of acetaminophen in my hand. So how does that tablet get into my body and actually relieve the pain in my head when I'm swallowing it orally, right? That's the pharmacokinetics that we're going to talk about, how it gets absorbed and distributed and metabolized and excreted once I take that pill. So this oral acetaminophen pill, I take it and I swallow it, and it has to pass through those epithelial cells in the lining of the GI tract to be absorbed. And with oral medications, there are many things that affect the absorption pattern, such as stability and solubility of the medication, GI pH and emptying time, right? If my emptying time is slowed down, that medication is going to stay in my stomach and not be absorbed and passed along. GI pH plays a huge role in absorption. When we start talking about antacids, right? Antacids change the pH of the stomach. They're not taken with any medications because of that. Because if I take an antacid and other medication, that's going to affect how that other medication is absorbed. The presence of food in the stomach or the intestines, other medications, and the forms of the medications. So enteric-coated pills or any sort of pills that are extended release, sustained release, controlled release, all those good things, you should already know, hopefully, that those are pills that you cannot crush, right? They have a coating that prevents them from breaking down quickly, so they're controlled as to how they're released. So enteric-coated or extended release pills you never want to crush. On the other hand, if you have liquids, they're already in a liquid form, any of those solutions or elixirs, and those will be absorbed quicker than a solid tablet because it's already in a solution form. Next, we have sublingual or buccal. Sublingual, sub being under, lingual tongue. Buccal, we're talking about in the cheek, where you're putting a pill to dissolve either in the cheek or under the tongue. Swallowing before dissolution allows gastric pH to inactivate these medications. So this is where patient teaching really comes in and is important. You need to understand how the medication is ordered, how it needs to be administered. Because if I have a sublingual nitro to give to my patient because they're having chest pain, and I give it to them with a glass of water and they swallow it, that pill will have no effect on them. They will get no relief from their chest pain, right? So it's important to know how these medications are ordered and make sure we're teaching our patients to take the medications right. In terms of absorption with sublingual and buccal, there's quick absorption systemically through high vascular mucous membranes. So the sublingual pill and the buccal pill will be absorbed quickly. With rectal or vaginal medications like suppositories, things of that sort, the presence of stool in the rectum or infectious material in the vagina limits tissue contact. In terms of absorption, easy absorption with both local and systemic effects for rectal and vaginal medications. Inhalation medications, absorption depends on the patient's ability to actually inspire, take that deep breath and get the medication deep into the lungs where it needs to be. Absorption pattern, there's a rapid absorption through alveolar capillary networks. Next, we have intradermal and topical. Absorption pattern is slow with gradual absorption. Effects are primarily local, but systemic as well, especially with lipid-soluble medications passing through subcutaneous fatty tissue. Next, subcutaneous and intramuscular. Barriers to absorption include capillary walls have large spaces between cells, therefore there's no significant barrier. That's a good thing if we want quick absorption. In terms of absorption pattern, solubility of the medication in water, highly soluble medications have a rapid absorption. Poorly soluble medications have a slow absorption. Blood perfusion at the site of injection. Sites with high blood perfusion have rapid absorption. Sites with low blood perfusion have a slow absorption. And then finally we have IV. There's no barriers to absorption with IV medications, right? We're administering the medication directly into the patient's vein, right? It's going straight into the veins, into the blood, and traveling throughout the body. It reaches the blood in its entirety also. So I'm not swallowing a pill that's then being processed by my liver, removing some of it and activating some of it, that type of stuff. It's 100% available in the blood after administration. And here's a list. We talked about some of these about factors that can affect absorption. The second phase of pharmacokinetics is distribution. Distribution is the transportation of medication to sites of action by bodily fluids. Factors influencing distribution include circulation, permeability of the cell membrane, and plasma protein binding. So let's talk about that tablet of acetaminophen again. So the first phase of pharmacokinetics, absorption. I've taken my tablet, I have swallowed it, it has been absorbed, and now it is traveling through my bloodstream. That's distribution, right? It's now traveling, it's being distributed. So these factors that influence distribution, circulation is one of them. Conditions that inhibit blood flow or perfusion, such as peripheral vascular disease or cardiac disease, can delay medication distribution, right? So if the medication is traveling through the blood to get to where it needs to go, and the circulation or the traveling of the blood itself isn't working well, that's going to affect distribution. Secondly, permeability of the cell membrane. The medication must be able to pass through tissue and membranes to reach its target area. Medications that are lipid soluble or have transport systems can cross the blood-brain barrier and the placenta. Thirdly, plasma protein binding. Medications compete for protein binding sites within the bloodstream, primarily albumin. So when you hear albumin, usually there's two things you should think of. One, it's a protein for sure. And two, a lot of times this is a side note, it can be associated, it can be looked at to determine the nutritional status of your patient. For our purposes, albumin, it's a protein, and sometimes medications bind to these proteins. Some medications do more protein binding than others, and it's important to know this when you're researching your medications. The ability of a medication to bind to a protein can affect how much of the medication will leave and travel to target tissues. So if I have warfarin is the medication that I usually talk about when I talk about medications that are highly protein bound. So warfarin is an anticoagulant. The layperson might call it a blood thinner, and it's a highly protein bound drug. So when I take my warfarin tablet, it binds onto these proteins, right? It has a high protein binding, and when it's bound to those proteins, it cannot exert its effect in the body. So warfarin, highly protein bound, I take it. A lot of it goes to bind with proteins, and then it doesn't do its job when it's bound to the protein. So when 99% of the medication is bound to that protein, it's not having the anticoagulant or blood thinning effect, right, that it would if it were a free drug. So free drugs are able to exert their effect on the body. The problem is two medications can compete for the same binding sites, resulting in toxicity. So with drugs that are highly protein bound, let's say I take two. I have warfarin and I have another drug, and I'm taking them both at the same time. There's only so much protein in my body to bind to. So they're going to compete for those protein binding sites. And what happens is a certain amount of the drug that would normally be bound to protein isn't going to be, right? It's going to be free and able to exert its effect on the body. And that's where it can become problematic for the patient, because normally we know how much anticoagulation is going to occur when the patient takes the pill. But if they're taking the medication with other meds that are highly protein bound, they're going to have more free drug or an unpredictable sort of circumstance of free drugs that could be problematic for the patient. So depending on what's going on, either they're not given at the same time, there's increased monitoring of the patient when they're given that type of like a warfarin with another highly protein bound drug. But it's important when you're learning the medications to know if they're highly protein bound, and then to understand that if my drug is bound to protein, it can exert its effect. When it's a free drug, it does exert its effect, right? If I take two highly protein bound drugs, it can be problematic because I may have more free drug than I expected, and I worry about the medication having a toxic effect with that increased amount of free drug in the person's system. So metabolism changes medications into less active or inactive forms by the action of enzymes. This occurs primarily in the liver, but also takes place in kidney, lungs, intestine, and blood. But the big organ that you want to associate with metabolism of drugs is the liver, okay? So with metabolism, you need to understand the first pass effect. So when I swallow my acetaminophen pill and it gets absorbed through my stomach, the first place it goes is to the liver through the portal vein, right? So medications that are absorbed and go through the portal vein, they get metabolized through the liver. That's considered the first pass effect before it gets sent out to the body, right? And that reduces the bioavailability of drug, the amount of the drug available to be sent out and do its job in the body. So when I have an oral medication, it's going to have that first pass effect. The medications that don't have that first pass effect are going to be your IV medications, right? They have that quick absorption straight into the blood supply. Also, the sublingual medication skips that first pass effect. All other medications are not going to be 100% available because of the first pass effect. They're going to be partly inactivated by the liver. There are some medications that the liver changes into an active form, but for the most part, the liver is changing medications into an inactive form. So if our patient's liver isn't functioning properly, our major concern is going to be that the liver isn't going to be inactivating as much of the drug as it usually would, right? So if the liver isn't doing its job and the patient's still taking the same amount of medication, we worry about accumulation and toxicity of that medication because it's not being inactivated by the liver. The final phase of pharmacokinetics is excretion. So I've taken my tablet of acetaminophen, it's been absorbed, it's been distributed throughout my body, it's been metabolized into an inactive form, and now I need to get rid of it. I need excretion. The elimination of medications from the body occurs primarily through the kidneys. So with the metabolism, you need to think of liver, excretion primarily through the kidneys. Kidney dysfunction can lead to an increase in the duration and intensity of a medication's response. So it's important to monitor labs that reflect kidney function. And the labs that you need to know are creatinine clearance, BUN, and glomerular filtration rate.